So we'll continue with the nursing care of a patient with Cushing syndrome. Nursing assessment includes getting the subjective data, which also include past medical history regarding any pituitary tumors, adrenal, pancreatic, or pulmonary neoplasms, GI bleeds, frequent infections, any use of any corticosteroids, subjective data like malaise, weight gain, anorexia, polyuria, prolonged wound healing, easy bruising, any of these signs and symptoms, weakness, fatigue, insomnia, poor sleep quality, headache, back pain, joint pain, bone or rib pain, any poor concentration and memory. Also ask if patient has any history of negative feelings, amenorrhea, impotence, decreased libido, anxiety, mood disturbances, emotional lability, and psychosis. Objective data includes any presence of any truncal obesity, supraclavicular fat pads, buffalo hump, moon phase, hirsutism of the body and face. Any other objective data includes thinning of hair, friable skin, acne, petechiae, purpura, hyperpigmentation, purplish red striae on breast and abdomen, buttocks, edema of the lower extremities. Any hypertension, muscle wasting, thin extremities, awkward gait, gynecomastia and testicular atrophy in men, and in women if there is enlarged clitoris. Other objective data includes decreased potassium level, increased glucose level, dyslipidemia, polycythemia, granulocytosis, lymphocytopenia, and eosinopenia. Possible focused assessment findings also include increased serum cortisol levels, high, low, or normal ACTH levels, abnormal result of dexamethasone suppression test, increased urine-free cortisol and 17 ketosteroids, glycosuria, hypercalciuria, and osteoporosis on X-ray. Nursing diagnosis for the patient with Cushing syndrome may include, but are not limited to, risk for infection related to lowered resistance to stress and suppression of the immune system, imbalanced nutrition more than body requirements related to increased appetite, high calorie content of foods and inactivity, disturbed body image related to change in appearance from the disease process, and impaired skin integrity related to excess corticosteroids, immobility, and altered skin integrity. The overall goals are that the patient with Cushing syndrome will experience relief of symptoms, avoid serious complications, maintain positive self-image, and actively participate in the therapeutic plan. Nursing implementation. Health promotion is focused on identifying patients at risk for Cushing syndrome. Patients receiving long-term exogenous corticosteroids for a variety of diseases are at risk. Patient teaching related to medication use and the monitoring of side effects are important preventive measures. Patients with Cushing syndrome are seriously ill. Because the therapy has many side effects, the focus of assessment is on signs and symptoms of hormone toxicity, drug toxicity, and complicating conditions. Example, cardiovascular disease, diabetes, and infection. Assess and monitor vital signs, daily weight, glucose checks, and possible signs and symptoms of inflammation and infection. Because the signs and symptoms of inflammation like fever and redness may be minimal or absent, assess for pain, loss of function, and purulent drainage. Monitor for signs and symptoms of abnormal thromboembolic events such as pulmonary emboli, example sudden chest pain, dyspnea, and tachypnea. The signs and symptoms of infection and inflammation may not be as prominent as in other patients because of the loss of lymphocytes by the high steroids. The typical signs are not seen in signs of infection are not seen in Cushing's. Another important focus of nursing care is emotional support. Changes in appearance such as centripetal obesity, multiple sclerosis, hirsutism in women, and gynecomastia in men can be distressing. The patient may feel unattractive, repulsive, or unwanted. You can help by remaining sensitive to the patient's feelings and offering respect and unconditional acceptance. Reassure the patient that the physical changes and much of the emotional lability will resolve when hormone level returns to normal. If treatment involves surgical removal of a pituitary adenoma, an adrenal tumor, or one or both adrenal glands, nursing care will additionally focus on preoperative and postoperative measures. Preoperative or before surgery, the patient's physical condition should be optimized. Hypertension and hyperglycemia must be controlled, and hypokalemia may be corrected with diet and potassium supplements. A high protein diet helps correct the protein depletion. Preoperative teaching will depend on the type of surgical approach planned, hypophysectomy or adrenalectomy, and should include information regarding the postoperative care that the patient should anticipate. Patients may have an NG tube, a urinary catheter, IV therapy, central venous pressure monitoring, and leg sequential compression devices to prevent emboli. Postoperative care includes the risk of hemorrhage because the adrenal glands are very vascular. Manipulation of glandular tissue during surgery may release large amounts of hormones into circulation, producing marked fluctuations in the metabolic processes affected by these hormones. Postoperatively, blood pressure, fluid balance, and electrolyte levels tend to be unstable because of these hormone fluctuations. High doses of corticosteroids like hydrocortisone or Solu-Cordef are administered IV during surgery and for several days afterward to ensure adequate response to the stress of the procedure. If large amounts of endogenous hormones have been released into the systemic circulation during surgery, the patient is likely to develop hypertension, which increases the risk of hemorrhage. High levels of corticosteroids also increases the susceptibility to infection and may delay wound healing. The critical period for circulatory instability ranges from 24 to 48 hours after surgery. During this time, you must constantly be alert for signs of corticosteroid imbalance. Report any rapid or significant changes in blood pressure, respirations, or heart rate. Monitor fluid intake and output carefully and assess for potential imbalances. IV corticosteroids are given, and the dose and rate of flow are adjusted to the patient's clinical manifestations and fluid and electrolyte balance. Oral doses are given as tolerated. Keep the IV line in place after IV corticosteroids are withdrawn to enable quick administration of corticosteroids or vasopressors. Obtain morning urine samples collected at the same time each morning for cortisol measurement to evaluate the effectiveness of surgery. If corticosteroid dosage is tapered too rapidly after surgery, acute adrenal insufficiency may develop. Monitor for acute adrenal insufficiency in these patients. Vomiting, increased weakness, dehydration, and hypotension may indicate hypocortisolism. In addition, the patient may complain of painful joints, pruritus, or peeling skin and may experience severe emotional disturbances. Report these signs and symptoms so that drug doses can be adjusted as necessary. After surgery, patients are usually maintained on bed rest until the blood pressure stabilizes. Be alert for subtle signs of postoperative infections because the usual inflammatory responses are suppressed. To prevent infection, provide meticulous care when changing the dressing and during any other procedures that necessitates access to body cavities, circulation, or areas under the skin. Discharge instructions are based on the patient's lack of endogenous corticosteroids and resulting inability to physiologically react to stressors. Consider a home health nurse referral, especially for older adults, because of the need for ongoing evaluation and educational needs. Instruct the patient to wear a medic alert bracelet at all times and carry medical identification and instructions in a wallet or purse. Teach the patient to avoid exposure to extremes of temperature, infection, and emotional disturbances. Stress may produce or precipitate acute adrenal insufficiency because the remaining adrenal tissue cannot meet an increased hormonal demand. Teach patients to adjust their corticosteroid replacement therapy in accordance with their stress levels. Consult with the patient's healthcare provider to determine the parameters for dosage changes if this plan is feasible. If the patient cannot adjust his or her medication, or if weakness, fainting, fever, or nausea and vomiting occur, the patient should contact the healthcare provider for a possible adjustment in corticosteroid dosage. Many patients require lifetime replacement therapy. However, it may take several months to adjust the hormone dose satisfactorily, and patients should be prepared accordingly. The expected outcomes are that the patient with Cushing syndrome will experience no signs or symptoms of infection, will attain appropriate weight for height, verbalize acceptance of appearance and treatment regime, and demonstrate healing of skin and maintenance of intact skin. So, in summary, Cushing syndrome is a clinical condition that results from chronic exposure to excess corticosteroids, particularly glucocorticoids. The most common cause is the administration of exogenous corticosteroids, example prednisone. Most cases of endogenous Cushing syndrome are due to an adrenocorticotropic hormone secreting pituitary tumor, pituitary adenoma, or adrenal tumor. The key manifestations include central or generalized obesity, moon phases or fullness of face, purplish red striae below the skin surface, hirsutism in women, hypertension, and unexplained hypokalemia. Treatment is dependent on the underlying cause and includes surgery and drug therapy to normalize hormone levels. Nursing care revolves around the risk of infection, imbalanced nutrition, disturbed self-esteem, risk for injury, and impaired skin integrity. Lifetime hormone therapy is required by patients who undergo bilateral adrenalectomy or hypophysiectomy. Care instructions are based on the patient's inability to react physiologically to a stressor.